Great. Thanks very much. So
All
we
right.
now welcome our second speaker today. It's Rudy Stoltzfus. She is a nurse at Grace Community Home Health and here to talk to everybody about what is home health. It's a very little understood benefit as part of Medicare. And I hope she'll also talk about some of the great therapists that are available at Grace Community Home Health. Take it away, Rudy.
Okay. Hello, everyone. Thank you for inviting me. Actually, this is a good opportunity to share a little bit more about what home health is and what Medicare covers, what doesn't cover. We get a lot of calls during the day asking about home care and home health, and there's a lot of confusion in the community about what exactly home health is and what home care is. So what I am today, I'm representing the home health realm of what the Medicare benefits are. So just a little bit about myself. I have been a nurse for over 14 years, long worked in hospital, long term. I've been in home health for over 10 years now. Worked with Stanford team and a lot of projects for their nursing homes during the pandemic and everything. And I do believe in providing excellent care, quality of care for all the patients, regardless where they're coming from, regardless of the age, gender, and background. And at Grace Community, we do take that to heart. It's actually part of who we are and what we do now. I thought this was going to be kind of an interactive part, but it's okay. I'm just going to troubleshoot. So question was, have you ever had experience with home health in the past? And this is where I would ask you, and people will share yes or no. If you have had home health in the past, this is a good opportunity now to compare with what you have received before and what actually should look like. If you have not, this is a great opportunity for you to get introduced to it. So just a little bit about Grace Community Home Health. We have been around now for 10 years. We just celebrated our 10 years anniversary. We're located in Mountain View, and we are a faith-based organization, and we take that to heart. That's actually in our mission and vision. It's pretty much everything we do is centered to loving others, loving the community, sharing with the community as much as we can, and really helping wherever we can. We're very passionate about Parkinson patients. Our team is all LSVT certified. For those of you who are familiar with the Lee Silverman voice treatment, that is physical therapy, occupational, and speech as well. We are the only agency in the Bay Area that has all disciplines available. And we have all our clinicians actually are certified to be able to carry the program wherever they are in the patient's home. We are medical services only, which means they're physician ordered. We do not provide custodial care or home care, which that is kind of the second part of home care that we get questions about. Those are usually caregivers or companions, and they're not medically ordered by the doctor. So Grace Community is strictly a medical facility. I say facility, we're agency, but we do not have a facility itself where we actually take patients in. We come to patients' home. Just a little bit about Medicare and the requirements for it in general. The goal for home health is to really provide the treatment for an illness or injury. Unlike the hospice, how Chris was talking about, is more really directed towards comfort care. At the end of life, Grace Community is at the other end of the spectrum, which is the curative part. We come in, we're short term. We want to make sure that we help your loved ones or to get better, to manage better in their own environment and really regain as much as they can from their independence. The goal is for them to become self-sufficient and receive less and less care from maybe caregivers or loved ones. It just releases the burden from everybody else and gives them a good opportunity to really maintain their independence. We want to make sure for those who really cannot make more more progress, at least they maintain the current level of function that they have. And at times it's really kind of preventing that slow decline. And oftentimes it's just really establishing a home exercise program for them. And we see that with a lot of our Parkinson patients is a little bit of a tune-up, it was going to take them a long way. So that's what we're looking for to really helping out the community. There's data and research out there, and it shows that, almost 10% of Medicare beneficiaries used their home health benefits in 2010. A little bit of data that was, the pandemic kind of stopped a little bit more the research and releasing a lot of information. But if you look at those numbers, only 10% of the people actually have utilized those services. A lot of the people either pay for the services out of pocket, or they don't even know that this benefit exists. So just going back is Medicare Act has been established under Title 18 for Social Security in 1965, and provides the health insurance for individuals of 65 and older. Those of you who have paid into it, you know what that is. We're actually the younger generation. We're paying into it ourselves now. And it has now expanded to permanently disabled individuals under 65. It's a different criteria, but a lot of actually people who have certain disabilities, they can qualify under Medicare as well. So eligibility, what is it? What's the eligibility for home health? Well, what does it really take for one to be covered under those services? Well, the first thing that you need to have a physician. And Medicare, again, we're a Medicare facility. We're licensed by the federal government, the state, and we really follow the rules. They tell us, okay, in order for this person to be eligible for the services, you got to have this criteria. One of which is you have to have a physician, whether it's your primary care physician, whether it's your neurologist, whomever is willing to take ownership of that person's care. It will be the one that will write the orders. I know earlier was a question that was asked, well, what about the cardiologist? What about the neurologist? We oftentimes work with primary care physicians, not always. Neurologists are very good, and we work with some of the great neurologists here in the Bay Area, and they actually decide to, they're going to send us a referral. We do the therapy with them. We send all the paperwork and the updates to them to let them know how the patient is doing, and then they sign everything. So what we do is we send a copy to the primary care to let them know, hey, this person is under our care. Even though it's managed by the neurologist, we want you to know what's going on as well, so that when they see you in the office for follow-up appointments, they know that you're receiving some of the home health services. The other criteria, it has to be services must be provided by a Medicare certified agency like us. They have to be intermittent, meaning it has to be a break in between. If you need everyday therapy, home health is probably not the right realm to go. If you need home health, if the patient is a lot sicker, requires a lot more help, at that we actually discuss a different level of care, which is a higher level of care. We provide physical therapy, speech, we have occupational therapy. The other criteria that is very important is the homebound requirement. Medicare is very straightforward about that. It's someone who has to have taxing effort to be able to qualify for it, meaning you really can't get out of your house. You're having trouble going to doctor's appointment, having a change in condition, something happened. Most of the time, the people are kind of in between. I was getting outpatient therapy, but now the Parkinson is exacerbated. It's a lot worse now. We can no longer go to outpatient. That's when home health comes in. That's under the homebound criteria. If it takes taxing effort for that patient to go to the appointment, then that is the right time to ask your doctor, well, would my loved one benefit from home health services? With the homebound criteria, there are exceptions to the rules, one of which They do allow patients to go to church if they need to go. This is very important spiritually for them and for their well-being. They do allow going to get your hair done. That's another thing is very important for someone. If if there's someone who had valued their looks their whole life and now they're not able to do that, Medicare will actually allow that under their homebound. There are special exceptions, which is once in a while, and I can answer those. Those are kind of very situational ones. But for sure, daycare facility, a lot of the patients are going to adult daycare. And that is one of the benefits that will qualify you under home health. So Medicare will allow that to happen. Add-on services for us will be a home health aide. They would usually come in for the patients who are very low functioning, meaning they do need a lot of help with bathing. They need a lot of grooming. They need someone to help them out there at all times. Home health aide alone cannot be in home health. They always have to have a nurse or a physical therapist or occupational therapist need with them. They're the ones that are really managing the care or social services, just like Chris was kind of sharing before. Our social workers will help the family through providing community resources if you need. They will go over the advanced directives if that's needed. For some of the low-income seniors or low-income patients, they will help you process through applying for Medi-Cal. They oftentimes help if those who do have Medicare and Medi-Cal at the same time, they will help them transition to when the time comes and they need a caregiver. Medi-Cal offers what we call in-home support services. So they will help them fill up all those paperwork and be able to apply for those services that you can benefit from. It's paid by the federal government. And they have a pool of money that they really invest in this in-home support services, which are caregivers coming to your home. And of course, we provide the medical supplies. We see patients anywhere from major wounds to very simple stuff like pill boxes. Those supplies are usually provided by us. We do not provide if someone has a prescription for IV fluids or IV antibiotics, we will come to your home and provide those services, but we do not provide the supplies. So usually those come from the pharmacy, and they're also covered under your insurance. So what isn't covered, just kind of as I was mentioning a little bit earlier, is 24-hour-a-day caregivers, meal delivery, like Meals on Wheels. Those are not covered. Those are a county or a state kind of program that's run by different entities. Homemaker services like shopping, cleaning, and laundry, those are not part of our services. Those are usually home care. Custodial care or personal care, just kind of how I mentioned earlier, bathing, dressing, using the bathroom. It's a little bit different than the home health aide. The home health aide will come in for 1 hour or so. We'll help with the bathing at that time, and then they'll leave. Those are services for the home care that there are specifically to provide that like for a certain amount of hours a day. And those oftentimes are out-of-pocket services. So meaning you will be paying for them privately. Now, if let's say the person has in-home support services benefit, then this service will actually be part of the services that they provide. So just briefly, a little bit about our nurses do. I had a lot of physicians at some point asking, and they said, well, what are your nurses doing when they go to a patient's home? Why would they need nurses? Well, nurses, they do act as case manager, and they have a lot of resources as far as, kind of helping you through what you're going through with the changing condition, because when someone needs home health services, it's a changing condition. It's not something that someone has had this condition for a while. They've stayed at the same functional level. Typically, there's something that happened. Either they went to the hospital, the Parkinson got worse, or they've had a fall. So that's when we come in. So the nurse will come in, will help with that. They help with medication management. Some patients come home with IV therapy. Very often nowadays, we treat the patients at home. We no longer, they don't want to go to nursing homes after the pandemic. Unfortunately, there's been a lot of, I don't want to go to the nursing home. That's where I got COVID. And it's this situation where people say, I prefer to go home. I prefer to have home health. So that's when the nurse will come in. I'm a wound care specialist myself. I've been certified for over 10 years now. I love wounds and I deal with complicated wounds. A lot of the patients who are, advanced Parkinsonism, for example, they will have a lot of bed sores. They're not able to move in bed anymore, and they'll have those major ulcers that it just, they're very painful, they're very uncomfortable, and they need to be taken care of. Otherwise, they're going to get worse. So that's when our nurses will come in. And they'll do teaching, they'll do caregiver training, they'll do they'll be monitoring and measuring the wounds every single time they come in. And of course, they'll be supervised. Supervise home health aides, we supervise the OTs, everybody on the medical team is pretty much able to function on their own. We like to have supervision. We like to make sure, Grace Community is being now one of the best agencies around, and we want to maintain our quality of care. We don't want that to be affected, so we do a lot of supervision visits. We just want to make sure that everybody is receiving the care that we have committed to. Physical therapy. So what would they be doing if they won't come to your home? Well, it can be from just the typical home health services that one receives, where they work with balance and gait and strengthening exercises. They'll design that program specific for your loved one after they assess them. That's the home. They will come, they'll do an evaluation. They'll kind of work with you and your loved one to say, okay, what are your goals? Where do we want to be moving forward? And they'll do that. And then there is the LSVT part, where there's a specific exercise for those patients who are able to participate in a program. And I'll be curious at the end of this if you guys are familiar with the program and what it really entails, or I can speak a little bit more about it. But they will do that. If they haven't had LSVT ever, there is a very intense program that they can be part of, or they can just do physical therapy. Same thing for occupational therapy. The occupational therapy really focuses more on activities of daily living. They focus on the functional part of rehabilitation and getting better. They focus on making sure that the person has the functional ability to put their clothes on, to go to the bathroom and be able to clean themselves and put their shoes on. And things like that. Not all Parkinson patients are advanced Parkinson's. There's different levels of it, as we all know. And the occupational therapists, oftentimes, they will really, really be good about setting up the house. They'll make the recommendations on what would really help them out. We have some equipment, some durable medical equipment like U-step walkers and all these other things that are designed specifically for Parkinson's, that we can recommend and work with your physician to really get it. And then the speech therapy aspect of it is, the hypophonia, the low voice, the ability to really express themselves in Parkinson in general is one of the things that we see the most with, advance as the Parkinson's progressing. But we also do dysphagia. We do swallowing evaluations. We do cognition evaluations. We work with that part of the brain that will help rewire and really the neuroplasticity and really make sure that they're starting to think big again and they're starting to speak big again. And those are things that we can definitely work with, specifically Parkinson patients. In general, for the rest of the patients, we will do evaluation for swallowing, we'll do cognition, they'll do all kinds of things that will engage the patient to be able to facilitate the swallowing. They will be assessing also when the decision whether are they going to get a feeding tube, is the feeding tube even feasible, or where are they at this point if they're able to swallow or not. So the speech therapist usually will help guide that. Special programs, we have fall-free programs. We do that for every single patient that comes to our agency. that it's part of the admission package that we want to make sure that we raise awareness about falls. We see so many falls during our programs, and a lot of the patients end up in the emergency room because of the fall. Parkinson, especially Parkinson patients, have really high risk of fall. So the therapist will work with you on that, and they will again design the program based on what their needs are. And then, of course, the LSVT big and loud that I was just mentioning earlier, those are specific exercises that are being done at different levels of Parkinson's based on where the progression is. So what do you need to start care? Let's say, you identify the need for home health. Of course, first thing first, you will need a physician order. You need to discuss that with your doctor. The doctors know very well about home health services and the criteria for them to qualify. Sometimes there's a gray line between the homebound status. They don't always necessarily take that into account, and they'll let us figure out whether the person is homebound or not, which is totally okay. We love collaborating with the physicians. And then, of course, there's the criteria. Just wanted to share the insurance that we take is we take Medicare. We're contracted with Health Net. We are contracted with Brand New Day. We are contracted with both Health Plan of San Mateo and Santa Clara Family Health Plan. We call it Dual Connect now. I think they just changed it. It's a Medicare Advantage plan. So if your loved one has signed for the Medicare Advantage that's managed by Santa Clara, that we're contracted with them. And of course, we take private pay. We do a lot of private pay for Parkinson's patients after they're completed their LSVT program. Because they want to continue. You know, there are different areas for the LSVT where you have the intense program or you have the maintenance program, and then once in a while you have what we call a tune-up program, so that they will, be able to once in a while kind of go back and revisit those areas again. And of course, you have to live in our coverage area, and our coverage area is from San Carlos. We start on San Carlos, even though we're located in Mountain View. We start in San Carlos, Redwood City, Palo Alto, Mountain View, and we move on the other side. We do cover Los Altos, Atherton, Woodside. We do go to Portola Valley, Sunnyvale, Santa Clara, and Cupertino. We have not opened it up to San Jose yet. It's just we want to make sure that our team, before we commit to anybody for that, we want to make sure that our team is available for that. So right now, those are the coverage area for our services. And that is the end of my presentation. If I haven't covered anything and you have some questions, please let me know. I'll be more than happy to answer them.
Thanks very much, Rudy. I had a couple questions. I know you have a speech therapist, as you said, who's LSVT loud certified, and I know you have a couple of PTs, I believe, who are LSVT big certified. Do all three of those people work from San Carlos to Cupertino?
Yes, and actually, that's a great question. Is all our therapists are LSVT certified. We actually invested in everyone, and we had them all get certified. So all the PTs and OTs and the speech therapists are all LSVT certified.
Okay, great. We should send you a link to our webpage that lists the PTs and speech therapists on it to be sure we have everybody listed, because I think we only have one speech therapist and two PTs, which is fantastic. As you said, you're the only home health who does that.
Yeah, we can do that. Yeah, we can update them. Usually, I thought it was the LSVT themselves, or someone's been updating it, because we're getting a lot of phone calls from them asking for a specific therapist. So I thought it was once when they get certified, then their name will kind of go in the system and they'll know. But yeah, I'll be happy to do that. Absolutely.
Yeah, sounds good. I'm sorry, I have pounding on my roof, as I mentioned. I'm getting it re-roofed. Somebody asked, is there a home health agency you can recommend, or even give the name of, not necessarily recommend, who covers north of San Carlos?
For LSVT, there are not other clinicians out there. However, there are a lot of home health agencies that do provide home health services out there. There's quite a few actually.
Yes, and I know that a very good place to where Rudy mentioned that Grace Community Home Health had that 5-star rating. That's on the Medicare website, and you can go there and find home health agencies in your geographic area and see the ratings. And as Rudy said, 5 stars it's the highest rating you can get, and it's pretty hard to get. So.
Yeah, and it's really easy to compare actually. There is an option. You go type in home health compare and it will come as a Medicare website. And then you type in either the zip code or the location. And then it will give you up all the agencies that are within that zip code. And then you actually will give an option to compare them to see who has the best rating, and it allows you to see the patient satisfaction survey, because that is something that is not controlled by us. The patient satisfaction survey is actually controlled by Medicare. They actually want to have a third party checking that. So the real results that you see there, they're not going through the agencies. They're going directly to the Medicare, that the questions that Medicare have designed for the patient.
Right. Okay. I have a question. Can people continue to receive LSVT services, or both LSVT big and LSVT loud, um, for forever through home health, or or is there some cap on that? How does that work?
Great question. Yeah. So Medicare, as you know, I mean, I hope you guys know, but every year they kind of been cutting costs on what they cover and what they don't cover. Medicare will cover for as long as there is progress. And what that means is that when we start and we evaluate your loved ones, they will have to continue to progress on their condition. Otherwise, we will not be able to continue. So there's two things that could happen. It would be that the goals are met and we're ready to discharge. That's why we're short leave. We come in for a short period of time. Medicare usually pays us 60 days, and they'll say, you have 60 days to make sure that this person actually progresses, they're receiving their therapy, they're doing really well. If they're not, then you're going to have to consider discharge. So there's time where we have to see progress in order for us to continue with the services. And it's very clear on Medicare. If you have not, let's say the progress hasn't been met, or is what we call a new baseline has been reached, meaning that will be moving forward, that's their baseline, they can't do any better than that, then that's the time that we will discontinue services. And there is an option where oftentimes you can transition to outpatient therapy. You know, Stanford used to have their LSVT program out there. I don't think they have it anymore. And then the Parkinson Institute used to have an outpatient rehab as well for LSVT specifically. So I don't think they have that. I'm not 100% sure. I would look into it.
Just two bits of information about that. So the Parkinson's Institute no longer exists. It hasn't existed for maybe 4 years now. And Stanford still does have outpatient PT and speech therapy and OT, but you have to be a Stanford neurology patient in order to be seen at Stanford.
Okay, thank you for clarifying. Yeah,
Yeah.
so that's what happens usually when we discharge. Now, let's say there's a change in condition and something happened. You know, there are times when your loved ones will get worse for whatever reason, and then they fall, and then they kind of have that need again. Then we will come back and we could do the exercises. The only thing that we cannot do, and this is specific from the LSVT requirements, is you can do what we call a maintenance or a tune-up, which means they'll come. Now, they're not going to come 4 times a week. They're going to come 2 times a week, and they're going to continue to kind of reinforce the exercises. It's a very, very intense program. And that's why, it's not for everybody. Patients really would have to be able to actually tolerate the exercises every day in order for this program to work. Otherwise, that's why we do the maintenance part, which is twice a week. And they will, again, it really has to do with progress. And that's the Medicare rule. As long as they make progress, Medicare will pay for it.
Okay,
Does
sounds
that
good.
answer your question?
Yeah, that does. Thank you. Could you say a little bit more about that Falls free program that you guys offer um, just as a matter of course?
Yes, yes. So what we do is usually we will go when we admit the patient to their home. One of the first things we do is we will assess the home for safety. But one of the part of our program is actually engaging the patient or the loved ones themselves. And we have questionnaires that we go together. The patient fills up on their own. It's really making them more aware of, oftentimes they'll say, well, I don't fall. I don't fall. I don't, everybody kind of looks at things very differently. So we will have them fill out this very simple questionnaire about where they are. And at the end, they will grade themselves and they'll see the fall risk they have. When we realize, the level of their falls, then we have different exercises that we're going to go with them. And then we're going to work with them specifically to make sure they meet that and it gets the strength they need, it gets the stability, and oftentimes it's gait issues, and we address those issues based on the questionnaire that they fill out, the of course the assessments that we have done, and we put them together and we really personalize it to that patient to make sure that their fall risk is being addressed.
Okay, thank you. I wanted to ask about, you said you were a faith-based organization, and I didn't know that was the case. Uh, I assume you take clients who are not faith-based.
Yes, that's wonderful. That's a great question. And I was going to mention that at the end. So, yes, we are a Christian community. We are faith-based organization. It is in our mission and vision, but we do not discriminate against anyone. In fact, we're equal opportunity employer. Not all our team members are Christians. They're of different faiths or no faith. But our core and our mission is to love on others, to make sure that we provide the best home health that there is out there. And it's a commitment to all of us in the leadership and the people who actually have founded this place, is to make sure that we love on everyone. So to us, it translates as you gotta go out there and you have to provide the best care out there to be excellent in everything we do. And that's what really, means to us is we have Christ as the center of who we are, but we don't discriminate against anyone. But when we provide our care out there, we allow that to speak for itself.
Okay, great. Can you talk a little bit about, I asked this question of Chris Rizzo as well. Can you talk a little bit about what interaction you have, if any, with the referring physician or the ordering physician?
Yes, we do have, there really are our supporting, well, we need them, and they need us to give them updates to let them know how the patients are doing. So we will receive, once when we receive the referral, we communicate directly with the physician. We work with a lot of doctors. They've already, very closely, they've shared their phone numbers and everything with us, and they work very closely with their patients. So we have access to Stanford. We have access to Palo Alto Medical Foundation, to their system. We're able to see, once we receive the patient's referral, we're able to not only look at that, but we look beyond that. We do communicate with multiple levels of physicians. We do go primarily to the primary care physician if the referral comes through the primary care physician, and we give them routine updates. Our documentation that we have for our system, it actually, the clinician writes up everything about the patient, what they found, what they're working on, so that they will give routine updates to the physician. And physicians, we got a lot of feedback from it. They love the way we have the format. Is really, It's what we call a SVAR format, which is situation assessment, background, and recommendation. So we basically tell them everything is going on with their patient. We keep open communication when it comes to order, getting signatures. We are very big into preventing hospitalization. If there is anything that we can treat at home, we will usually go through the primary care physician and we will discuss that with them. Let's say there's a change in condition. Your loved one has all of a sudden become confused and they're having a lot of pain and they don't know what's going on. Our nurses, if you have the services, will come in and they'll assess your loved one. We will call the physician. We will make recommendations. Oftentimes, we do labs at home. We can do whatever they want us to. If we want to do a urine and get the urine and drop it off the lab, we coordinate those. They put the labs in the system. We drop them off at their lab, so they get the results right away. So the goal is to maintain the best optional possible outcome at the patient's home. So we try to avoid hospitalization if we can help it. I mean, there's times where we can't, like they need to go to the hospital because they had a fall and we're suspecting that it might be a fracture, or someone who's on blood thinners and they hit their head. Those are things that are more serious that there's really not much we can do at home. But the rest of the stuff, we can address a lot of the issues at home. And oftentimes it's with the support from the community physicians, where we give them a call. The therapists that we work with are very skilled into recognizing changing conditions. So they don't only do therapy. We train them to be able to recognize those early warnings. If something is wrong, they'll call the doctor. So we have very open communication with the community doctor, the doctor that actually refer the patient to us. And that's why oftentimes they love to send their patients over, because they trust us.
Okay, great. And I assume sometimes you do refer people to Mission Hospice and other hospice agencies when it seems appropriate to you.
Yes, yes, we do. And it's unfortunate kind of the way kind of things are going, but it is when we have given the best we could, when there have been situations where we tried the best and it's just the body's not, it's not working. Our team is very good about approaching the subject. We will consult with the physician first before we even make any suggestions or anything. It's really recognizing the level. And what we see with the patients a lot of the time is they don't know when to make that decision. It's a very hard decision to make, when to transition from home health to palliative care, which we work together with palliative care, but when is the time to transition to hospice? And that's when we come in and we kind of help you through making the decision, because it really is when there's no more progress that is being, but not just that someone stayed at the status quo, that they haven't, improved, is when someone's actually actively declining. And then you can see the declination, and there's really, unfortunately, there's not much you can do. So we have the discussion, we guide them through, we talk to the primary care physician. Oftentimes we're asked which agencies we recommend, and we kind of have like a handful of agencies that we've worked in the past 10 years. Mission is one of them. And then we transition them. We do the handoff. We call the physician. We ask them to make the referral, so that we ease the burden on the family, and they will be involved, on once when the mission comes in the hospice, and they'll kind of communicate and we'll transition off. Once when we discharge, we're there to support. We've always been there to support the families from whatever they need outside the home health realm. We do build a relationship with our patients and their loved ones, and they trust us to help them through the process. But once when they transition to hospice, then the home health services have to stop, so that the hospice services can come in. You cannot have both at the same time. We do work with palliative care, which is a different service, but hospice is a completely different realm.
Okay, I had one more question, but it's now escaped me. So if anybody has a question, let me know and I'll try to get my elderly brain going again. Um, you talked about uh, integration with very difficult hard transition between home health to hospice. So could you say like what the average, if there is such a thing, what an average Parkinson's patient experiences with Grace Community Home Health? How long are they with Grace Community Home Health? Is it a matter of going off and on?
It is. And it's, so first of all, it depends on what level the Parkinson's itself is at for each individual. For those who are more high functioning and they're able to manage very well at home, again, it comes into the homebound status. If they're not homebound, they'll go to outpatient therapy. But if they are homebound, we will come in and most of the time that I see, and I don't want to give a number to it because everybody's so different, is I see, twice a week for the next 4 weeks, and they'll be working on exercises, and then they'll cut down. Their goal really is to well, not one, establish that home exercise program, work with the caregivers or the loved ones, and then make sure that after they're gone, the therapists are gone, then they will, whoever is left at home, whether it's the caregiver or the loved one, they will continue those exercises. As long as they continue doing their exercises, the decline is usually a lot slower. And we do also get the type of patient who will do the exercise and is very motivated, and then as soon as the therapist is discharging because they reached their goals, then it kind of falls back and doesn't do the exercises anymore, for whatever reason. Maybe they don't have a caregiver. Usually we try to support them before we discontinue the services, we want to make sure there's someone there, and they will kind of name someone who will help them with exercises. And then if that happens, then, let's say 6 months or, depending on the time, if they get a referral again, it means that they kind of stop doing exercises or something else happened. I know I mentioned a lot of change in condition, but that happens so often with patients, whether it's the medication, whether it's a bladder infection, whether it's dehydration, or there's so many things at home that just the body might just change. So that's when we get the referral again, and we're going to go right back. And they usually prefer the same therapist. And we do try to be as consistent as possible, and we keep everybody with the same therapist. But that's kind of the cycle that goes through, because Parkinson is a progressive disorder. And what they do now, maybe 6 months from now or a year from now, is very different. So that's where we go back and say, okay, is there anything that we can work on with that? And there have been times where we've made great progress, and there's other times when we say, okay, well, this is where we are at this point, and then we bring up other avenues, whether it is, just the caregiver or the transition to hospice, or, it's really based on the patient itself and their abilities.
Right. Okay, one more question. You mentioned that somebody like a physical therapist can make a referral or can recommend to a physician to order a U-step walker
Mm-hmm.
or some kind of durable medical equipment. Similarly, would one of the physical therapists or even the nurse make a recommendation for orthotics if the person with Parkinson's has curled toes and difficulty walking?
Yes, yes. So part of the assessments that we do at home is identifying what their needs are. And if someone has that need, they will recommend whether they need orthotics or they need different shoes, or those are things that are done on evaluation. The U-step walkers are unique to Parkinson patients. We actually have one in the office. Before we even recommend it, the therapists actually bring it in and they have the patient try it out, because not everybody ends up liking it. You know, it's a little bit backwards than a rollator, which is a four-wheel walker. The brakes are a little bit different. You know, you have to kind of so it's a little bit different, but it's designed specifically for the Parkinson patient. So they will go in and they will identify. That's the role. The role of the therapist, in addition to providing the therapy, is to identify those needs, whether there is home modification, whether there is special equipment, orthotics, or anything that might support the patient to do better in their own environment. Great
Great.
question.
Yeah, very good. Thanks so much, Rudy. It was a fantastic presentation, and thanks to our participants for all the good questions. And thanks to Denise, my wonderful colleague who set up the speakers today, and also the speakers from last month too. It's a lot of work to coordinate a group of speakers, so she's done a great job yet again.
Oh,
So
there was
thank
a
you so much.
question. Yeah, there's a question there about, does the same PT come in every time with Grace, or different therapists come? We like to keep everything consistent. You know, patients do
Yeah,
build relationship. I think I said that. They build a
you
relationship.
you
Yeah.
answered that. Yeah, that's
Okay.
why I didn't ask that question, because
Okay.
you had already answered it by that time. Okay, very good.